today I shall be talking about developmental dysplasia of hip. Earlier it was called as congenital dislocation of the hip. Congenital means it was present since birth, but now if the dislocation of the hip presents after 1 year or 1 year of the age, so now the name has changed from congenital to the developmental dysplasia of the hip. This is the acetabulum, this is the femur head of the child, and due to any cause, if there is acetabular dysplasia and the size and shape of the acetabulum and the femur head is not complementary to each other, there will be displacement of the femur head. So primary etiology is there is acetabular dysplasia, and the associations, it is associated with torticollis or metatarsus adductus. What is the importance of association? If the child is born with torticollis, it is visible with our naked eyes, so that we can screen the child for developmental dysplasia of the hip. And DDH is more common in left hip. Why it is more common in left hip? Because in cephalic presentation, mostly the child is in left occipito and anterior position. Left occipito anterior position. And in this, the left hip of the child is against the sacrum of the mother, and when during the delivery of the baby, sacrum applied adductive force to the left hip, and if there is dysplasia of the acetabulum or shallow acetabulum, then there is displacement of the dislocation of the femur head. So it is more common in the left hip. Post-mature birth. During the normal delivery, there is increase in estrogen, increase in progesterone, and increase in relaxin. And this relaxin relax the interpelvic ligament and muscles of the mother to facilitate childbirth. But if the delivery time exceeds, then this relaxin enter the fetal circulation and it causes a relaxation of the interpelvic ligaments and muscles of the child. So, and if there is acetabular dysplasia and the shallow dip, and there is incongruency between the acetabulum and the femur head, then it gets dislocated. In female child, it is not the reason that pelvis is large in the female child, due to which DDH occurs. It is the polygenic trait in females that cause dysplasia of the hip, because during intrauterine life or during birth, the male and the female child have same pelvic grid. In oligohydramnios cause DDH. How it causes DDH? Due to oligohydramnios, crowding phenomenon occurs. Due to crowding phenomenon, there is not enough space for the baby to accommodate. So the baby hyperflex to accommodate in the little space, and in the process of hyperflexion, if there is acetabular dysplasia, there will be dislocation of the femur head. In firstborn child, there is also crowding phenomenon, as the fibers of the uterus are not elastic, not so much elastic that the baby can accumulate. So the baby goes to hyperflexion, and in the process of hyperflexion, to accommodate in the little space, if the acetabular is dysplasia and the shallow acetabulum, the femur head get dislocated. In breech presentation, without proper dilatation, it is the buttock which are getting presented, and due to adductive forces, the femur head get dislocated. Now talking about the clinical features. If the child have developmental dysplasia of the hip, then there will be limitation of the thigh abduction. Then the orthopedic surgeon will perform Barlow test for the diagnosis. Firstly, the orthopedic surgeon will dislocate the hip by doing abduction of the thigh. And after there is dysplasia, then autolynic test is performed to again keep the femur head and the acetabulum in the position. For that, we do reduction of the hip joint by doing abduction of the thigh. And if the child comes with congenital dislocation of the hip, then which test will be performed? We will perform the autolynic test, as the hip is already dislocated. And if there is suspicion that the hip has dislocated, then we perform the Barlow test. But when there is confirmation that hip is already dislocated, then we perform the autolynic test by doing abduction of the thigh for the reduction of the hip joint. Gallagher sign. In this, there is due to dislocation of the hip, there is proximal migration of the thigh. Suppose this is the child. This is the right leg, which is normal, and in this there is proximal migration of the thigh. And when we make the patient sleep on the couch and flex the hip joint, then the affected limb, height of the affected limb will be lower, will appear lower. This is called Gallagher sign. And there will be increased thigh folds medially and posteriorly on the affected side. Suppose this is the increased thigh fold, as there is proximal migration of the thigh. Increased thigh folds will be seen medially and posteriorly. Higher posterior gluteal fold. As there is proximal migration of the hip joint, posterior gluteal fold will also migrate in the proximal direction. Due to DDH, there will be no delay in walking of the child. Only there will be abnormality in the walking pattern of the child, and the gait we will see in the patient is Trendelenburg gait in the unilateral DDH. If the child has unilateral DDH, there is 18% of the chance that the child has bilateral DDH. It means that 1/5 of the child have bilateral DDH, and the gait in bilateral DDH, the gait which is seen is waddling gait, bilateral Trendelenburg gait, which is also called dog-like gait. Talking about investigation, screening investigation in newborn, we do the ultrasonography. In ultrasonography, alpha angle and beta angle is seen. Alpha angle is decreased. Normally it is 45 to 50 degree, and beta angle is increased. Normally is 55 to 60 degree. We did not perform X-ray in newborn, as acetabulum and head of the femur is cartilaginous and it is not appreciated in the X-ray. And best investigation for DDH is MRI. And it is not investigation of choice, and it is difficult procedure in the newborn. Now doing X-ray in the older children, as the bone becomes ossified, so it is appreciated. We make the Hilgen renal line passing along the triradiate cartilage, and we make the Perkin line along the outer border of the acetabulum, and tangent drawn with the floor of the acetabulum is the acetabular index. Normally it is less than 30 degree, but in DDH, acetabular index is more than 30 degree. Head of the femur, normally it lies in the inner lower quadrant. This is the inner lower quadrant, and this is the upper outer quadrant. In DDH, head of femur lies in the upper outer quadrant. Sentence line, which is the imaginary curved line formed along the superior border of the obturator foramen and along with the inferior-medial border of the neck of the femur. Sentence line is normal. Here it is normal, and in DDH, sentence line is broken. Talking about the treatment for neonate and young child up to 1 to 6 months, close reduction is done, and after reduction, public harness is used for maintenance of the reduction. For 6 to 18 months of the child, open reduction is performed, as close reduction is difficult, as there is hypertrophy of the ligamentum teres and inferior capsule of the hip become hourglass shaped. 18 to 36 months of the child, open reduction with femoral rotation osteotomy with or without pelvic osteotomy is performed. In 3 to 6 years of the child, open reduction, femoral shortening with rotation and acetabular reconstruction procedures named as Salter osteotomy, Chiari's pelvic displacement osteotomy, Pemberton osteotomy is performed. In children of 6 to 10 years, if there is unilateral DDH, then same procedure as above is done, which is open reduction, femoral shortening with rotation and acetabular reconstruction procedure named as Salter, Chiari's and Pemberton osteotomy. If there is bilateral DDH, then limp is not noticeable, so treatment is avoided unless severe pain and deformity. When there is severe pain and deformity, then intervention can be done. And when the child is more than 11 years of the age, they are present with osteoarthritis, which is painful, for which total hip replacement can be done. This is all for DDS. Thank you.